Good morning and welcome to the grand round. And this is a new semester. We don't have semesters here really, but you can call it a semester. And this is the first of it's the 16th, so people have just come back to work. And maybe not the best day to have a grand round, but anyways, we're having. And actually, all of due to COVID for so many months and years, actually, we never had a offline sessions. So we are restarting now. We're having initially at least in a hybrid mode, and then as we go along, we'll see how hopefully more and more people will come physically, and then we can have it mostly or only offline. That is the intention in due course. And we had a pretty good sessions last semester, last 6 months. Some of the presentations were really excellent, and the attendance was also much better than it was previously. So I hope that the trend will continue, because the grand rounds are actually something which is a common academic activity. There are very few of them in this institute, and we should nurture it and make it stronger. So today's grand round was by actually the Department of Hospital Administration, and they have and Dr. Harshvardhan suggested that the presentation by the Apex Trauma Center would be useful for everybody. And so I also thought that that was a good idea, because the trauma center, we all know that we have this trauma center, but what all it has, what other things which are done there, and how they are now doing once this COVID part of the problems are over, we can have a idea now. And so they are going to present a clinical overview of the trauma center and some experience. And I request Dr. Rajkumar, who is in charge nowadays of the trauma center, to come and to tell us a little bit, and then he can start off the presentation.
Well, good morning to everybody. Esteemed Professor is Bhatia-ji, senior faculty members, residents, and those audience who are connected with us. Well, it is the first session following the summer vacation. And I just want to briefly touch the importance of Apex Trauma Center at SGPGI. As we know that there are three main killers we were taught during our MBBS training. These were coronary, car, and cancer. Coronary means heart attacks, car means road traffic accidents, and cancers obviously we know about. We know that nearly 25% of all the deaths occurring throughout the globe are secondary to the cardiac diseases, cardiovascular diseases, which we can include obviously other than hypertension, diabetes, and its consequences. We can include cerebrovascular diseases, rheumatic diseases, cardiomyopathies, etc. But we have good cardiologists around in our country also. During last 3 decades, the cardiology and cardiovascular surgery has grown to a very prolific manner. In the same breath, I can say that the cancer, which is as per the report of Globocon, if I remember, 2012, a recent report has also come, if I am not mistaken. Nearly the incidence is 94 and 95 per lakh in population in India, which is relatively more in females. Fortunately, to combat with the cancer, we have grown in our country to deal with the cancer. Several cancer institutes and good onco surgeons and oncologists have emerged over last 2-3 decades. Unfortunately, The trauma, which is almost ignored, it is going to be the first killer by 2030 or 40, as it is estimated by WHO. It is ignored, and not many Apex or good trauma centers have come up across the country, barring the AIMS Apex Trauma Center. Probably none is functioning to the tune in which it could have been by now. Incidentally, probably we know, but yet we ignore it, that nearly 1 to 2 million people meet with the accident in India in 1 year, and nearly 2 lakh people die. Every minute there is an accident in India, and every 5 minutes one person dies. It is something very serious. And road traffic accident over last 10 years, from 2000 to 2010, the incidence increased to the 50%. With the growth of population, only 18% or so. We contribute to the 16 to 20% of total accidents of the globe. So need not to say, we top the list as far as the accident is concerned. The situation is quite dangerous. We don't teach our children's, bikers, pedestrians, even cars. We are all vulnerable any day for the accident. Ours is a very small experience with the trauma, because as we know, SGPGI turned the Apex Trauma Center to the COVID hospital because it stands alone outside the campus. So separate building was required. Twice we started Apex Trauma Center with meager faculty of 18 faculty members. Now only 17 are left. We are going to induct soon few faculty members and staff. So we have limited experience, but it is very useful. And neurosurgery is a main stakeholder in trauma, because most of the lives are claimed because of head injury. So neurosurgery has already presented CGR previously. So I will go ahead with the rest of the specialties. And second most trauma incidence which occurs in following head injury is the chest injury, followed by abdominal injuries, followed by orthopedic injuries, followed by maxillofacial injuries. This is rough estimate. So I will invite Dr. Amit, who is the trauma surgeon. He shall start with, and if there are further questions and comments, we will take at the later part of session. Thank you very much for giving audience.
Thank you, sir. Good morning. On behalf of trauma team, I would like to welcome everyone in today's clinical grand round. To begin with, I would like to thank Professor Bhatia sir, Professor Rajkumar sir, for giving us this opportunity to present our work on this academic forum. Unlike the previously presented CGR, this CGR is going to be somewhat different. Because, as all of you know, we are relatively new setup with effective working period of 2 odd years. As a team, we represent 7 major subspecialties of trauma, and this is our first CGR. So I will be giving the overview, which will be followed by one speaker from each specialty. So let's start with the history. The concept of trauma center was envisioned on the backdrop of Jai Prakash Nair Trauma Center, AIMS, New Delhi. It was envisioned by our seniors way back in 2010-2011. Somehow it went to KGMU administration, named as Trauma 2 or T2, worked as their satellite centers. But due to suboptimal functioning for the next 2 years, and with the change in the UP government, a decision was taken and the center was again came back to us. In 2018, the center was recommissioned with the main emphasis on R&R, that is the services from resuscitation to rehabilitation. As all of you know, and as Professor Rajkumar sir has rightly said, trauma centers are the need of the hour. The government is also focusing on opening of new trauma centers across the country. The society needs trauma centers. We will try to find answers through today's presentation. Why we need trauma centers? Trauma is a major killer. It represents 12% of the global burden of disease. In India itself, 1 million people die and 20 million hospitalized every year. So you can see that trauma is a burden not only to the individual but to the family, to the society, to the health sector, and to the nation. Trauma accounts to 11% of all disability adjusted life years. The road traffic injuries are major cause of mortality, but it's only a fraction of the trauma spectrum. And injury is the third most important cause of mortality among the young adults. If you see, trauma or injury, they account for 40% of the years of potential life lost. So this is the quantum of the trauma. If we see the epidemiology and pattern of injury, 31% are due to road traffic injuries or road traffic accident, whereas 26% occurs due to firearm injuries, 13% due to assault, 10% due to fall from height, and rest are due to other things. If we break up this road traffic injury data, we'll find that the motorcycle riders or the pillion riders, bicycle riders, in combination, they will account for more than 50% of trauma cases. Pediatrician, pedestrian, 8% cases, and the big heavy vehicles, just 3% only. As Professor Rajkumar directly says, neurotrauma is the major chunk which occupies more than 35 to 40% of all trauma patients, followed with abdomen and chest injuries, then long bone injuries, and then finally facial injuries, which accounts for 3% only. We in 2018 started our trauma center with a minimum facility and with minimum faculties of 18 young and enthusiastic faculties. We provide round the clock emergency services. We have 6 operating rooms. We have a blood bank extension counter, 13 bedded emergency with 5 red zone beds, 5 yellow zone beds, and 3 green zone beds. We have 23 bedded ICU facility, 60 bedded ward, 24 hours lab services, 24 hours radio imaging services, and of course, daily basis OPD of all the subspecialties. Most among of you must have seen the ETC during the COVID-19 pandemic. But today, let me reintroduce the ATC for the purpose for which it was conceived, that is, from resuscitation to rehabilitation. ATC provides round the clock services. Our structure is such that all trauma patients are first received in the emergency receiving zone, which is also a triage zone. Trauma triage is totally different from the triage which we know during the COVID-19 period. Here we follow advanced trauma life support protocol, that is ATLS protocol, which is being followed all over the world as far as the management of trauma patient is concerned. The triaging consists of 3 zones: red, yellow, and green. Most unstable patients are kept in red zone, while a patient which are somewhat stable are kept in yellow zone, and totally stable patients are kept in green zone. These zones are based. Pricing is a dynamic situation which changes as per the patient required, as per the patient requirement. Once the patient is triaged in the emergency area depending on the situation or condition of the patient. The patient is either being shifted to the ICU. We have 20 bedded ICU facilities, which is run by the Department of Anesthesia, and we get help from the nephrology department, from the CCM, and other facilities faculties from the SGPGI. The patient, we have 6 modular OTs in which different subspecialties provide all type of trauma services. Stable patients are managed in our 60 bedded wards on the 3rd floor. We run OPD on daily basis from Monday to Saturday. All the specialties, including neurosurgery, they provide their OPD services in the ATC for the trauma follow patients. From the start of ATC, that is from 2018 till the COVID-19 pandemic strike us, we managed more than 2,000 cases of acute trauma at our center. Out of this 2,088 cases, 1,365 were ward admissions, and more than 36%, that is 7 to 23 cases, required ICU care. And if you see the data of admissions, 1,670 patients were admitted through the emergency services itself, whereas 418 were follow patients requiring redo or multiple surgeries. Then something this happens, and there was a complete disruption of all services. The whole of humanity was struck by COVID-19 pandemic, and all of us suffered a lot on every aspect of life. Our center was turned in Rajdhani Corona Hospital, and we were given responsibilities of managing corona patients, which we did. Eventually, all bad things comes to an end. Slowly and slowly, after a span of 18 months, we started our acute services, followed by resumption of OPD services. During these last 6 to 8 months, we have treated more than 1,400 cases of acute trauma at our center, which include 317 patients requiring ICU care and more than 1,000 patients needed ward admissions. As you can see, majority of our admissions are from emergency department, while the ward admissions are minimal, just a fraction of 20%. Now let's come to the subspecialty wise presentation. I will be giving an overview regarding the trauma surgery. As a trauma surgery, in our center, we take care of the acute emergency admissions. We provide initial resuscitation. We do primary and secondary surveys. We do all type of blunt and penetrating traumas, firearm injuries, abdominal trauma, thoracic trauma, genitourinary trauma, extremity trauma, and damage control surgery. These are the spectrum of cases which we have did in previous years. Now I would like to discuss a small case. This is a 12-year male child which presented to us in trauma emergency with a fall from bicycle. There was an injury to the abdomen. Sign and symptoms, there was pain and tenderness in the abdomen, and the treatment which the child received before coming to us was symptomatic only. Injury occurs 5 days back. The emphasis is sometimes trivial trauma can be devastating and can have devastating consequences, like in this case. When we examined this patient, there was a tenderness present in the epigastrium region. However, there was no distension, no guarding, no rigidity, or what I can say, no sign of peritonitis. Lab markers were raised: serum amylase, serum lipase, all was grossly raised. We went for the radiological investigation. The FAST, that is focus assessment sonography in trauma, was done, which was found to be positive. CT shows grade 3 pancreatic injury with involvement of main pancreatic duct. Further line of treatment, we sought gastro-medicine consultation, implant and ERCP with stenting of main pancreatic duct on 14th of April. The finding were pancreatic duct disruption near the head, and a collection was seen with communication with the main pancreatic duct. The patient was discharged from the gastromedical medicine department and was symptomatic. Then again the patient reported to us after a span of 2 months with a chief complaint of nausea and vomiting for the last 3 days. On clinical examination, there was a lump in epigastric rhythm which was firm in consistency. Laboratory investigation confirmed our suspicion regarding injury to the pancreas. There was raised amylase and lipase level. We went for the radiological investigation and we found a large pancreatic pseudocyst in the peripancreatic region. So a bit about the pseudopancreatic cyst. It is nothing but a fluid collection contained within a well-defined capsule of fibrous or granulation tissue or a combination of both. It doesn't possess an epithelial wall. Sometimes it persists for more than 4 weeks, and most common cystic lesion of pancreas, 75 to 80% of cases, is pseudopancreatic cyst, and its normal location is lesser sac in proximity to pancreas. So there are few indications for intervention in a pseudopancreatic cyst. Most of the time it's managed conservatively. Intervention can be done either through percutaneous route, endoscopy route, or surgical route. So depending on the condition of the patient and the findings. So what we did in this case, we went with a CT guided transgastric percutaneous catheter drainage along with supportive medical care that include intravenous fluids, analgesics, and anti-emetic with low fat diet. The child is still admitted with us and responding to the treatment. So what we can say is pancreatic pseudocysts are the sequelae of traumatic pancreatic injury. Initial management consists of supportive care. Persistent symptoms and development of complication warrant invasive intervention. A tailored therapeutic approach taking into consideration patient preferences and involving multidisciplinary team of therapeutic endoscopists and intervention radiologists should be considered in all cases. Now, I would like to invite next speaker, Dr. Kumar Keshav from the specialty of orthopedics to carry forward this presentation. Thank you.
Thanks, Dr. Amit. That was an excellent presentation. Now I'd like to touch a few things about the specialty of orthopedics, and for the purpose of CGR, we have tried to bring about some cases from pelvic vestibular domain, our initial experience. So before starting the actual topic, I would like to give a brief overview of the cases that we have done. Till now, we have operated 1,300, more than 1,300 cases, and for 16 months during the COVID period, we did not operate a single case, and that brings to an average of around 45 per month. The domain of our work includes basically the orthopedic trauma, the sports injuries, the pelvic vestibular trauma, also the spine trauma, joint replacement and reconstruction, and joint preservation surgeries. Now the OPDs, in OPD we have seen close to more than 23,000 patients, and if we exclude the COVID period, we have been seeing around 642 patients per month. A substantial number of OPD patients includes the referred cases from the various main parent departments of SGPGI. Now coming to the actual topic, the pelvic vestibular fractures, our initial experience. So contrary to what most of the people feel, the pelvic vestibular fracture is not a single entity, it's basically two different entities. The pelvic fracture essentially means the fracture of any disruption in the ring which is formed by the two innominate bones and the sacrum. And on the other hand, the vestibular fracture is basically the hip joint. Hip joint is a ball and socket joint, if there is a fracture of the socket of the hip joint, that is the fracture of the acetabulum basically. And there are certain fractures where the fracture line may include both the pelvis, that means it can cause the disruption of the ring, as well as fracture of the socket, and those fractures are known as combined pelvic fractures. It includes only 10% of the whole set of the pelvic fractures. Now the pelvic, first I will discuss the pelvic fractures. The pelvic fractures are important, especially from the trauma point of view, because it causes too much of blood loss. As much as 3 liters of blood can be lost in a single, in case of pelvic fractures. The patient often presents in shock, and this is one of the rare fractures in orthopedics which is actually life-threatening. Most of the orthopedic injuries are limb-threatening, but this is life-threatening. The emergency management is by the application of a pelvic binder, and these fractures are often associated with abdominal and genitourinary injuries. The management basically depends upon the type of injury. The injury can be stable if only a iliac wing is fractured. It can be rotationally unstable, or it can be vertically unstable. So the management can be conservative. We can apply an external fixator. The definitive internal fixation by plating can be done. And in certain cases where the pelvis is disrupted from the spine, we have to go for a spinopelvic fixation. At ATC, we operated 15 such cases and managed 55 conservatively. Now I'll go one by one to show some of the cases, starting from the most simple ones to the complex ones. So as you can see in this patient, 39-year-old male patient, there is a fracture only of the iliac wing. The pelvic ring integrity is intact. Apart from this, the patient also had a fracture of the clavicle, multiple ribs, a fracture of the both bones of leg. And since this was a stable variety of fracture, we have operated this patient conservatively. And you can see that the patient is able to sit, squat, and stand at 6 months. Now going to a bit complex, as you can see, this looks like a similar kind of fracture, but there is avulsion of the anterior superior iliac spine where the inguinal ligament and the sartorius muscle inserts. And so this fracture needed to be managed surgically. We went ahead with the fixation of the ASIS, anterior superior iliac spine, by 2 cannulated cancellous screws, and also fixed the ilium. And you can see that in the just at 3 months, the patient is able to walk. This is a scar mark of the surgery. Now the third case, this patient is one of the most severe varieties of pelvic fracture. In this patient, there was spinopelvic dissociation. There was fracture of the sacrum on one side, on the right side, and the sacroiliac disruption on the other side. And there were fracture of the both superior and inferior pubic rami on both the sides. This patient was first managed from the posterior aspect in the prone position. In the prone position, we fixed from the spine. We did a spinopelvic fixation. Then we turned the patient, made him supine, and we fixed the bilateral sacroiliac joint by sacroiliac screws, and we applied external fixator anteriorly. Because of the competent physiotherapy team at Apex Trauma Center, we started the rehabilitation of the patient right after the surgery. As you can see that the pelvic fixator is still in place and the patient has started doing physiotherapy. After 1.5 months, we removed the external fixator, and as you can see that at 3 years, the fracture is well healed, the anatomy is grossly restored, and the patient is back to his normal life. Now I will discuss a certain few things about the acetabular fractures. These fractures are not really an so-called emergency, but these are important from the point of view that these can give rise to post-traumatic osteoarthritis of hip if not managed properly, and that can require total hip replacement in the future. The anatomical reduction is a must, and which is usually not possible by the conservative means, and so we have to usually operate such kind of patients. The surgical approach depends upon the fracture pattern, and it can be managed. We have to either go from the anterior approach or the posterior approach, or many times from both the approaches. At ATC, we operated 13 such cases and managed a single patient conservatively. So this is one of the most common cases. There is a hip dislocation of the hip joint, as you can see over here. There is a fracture of the posterior wall of acetabulum, and in this case, we had to open the acetabulum from the posterior aspect, the Cocker-Langenbach approach. We reduced the fracture and we fixed it by the help of a Marta's plate. And as you can see in the post-operative CT, the hip joint is well congruent and the dislocation has been reduced. And just at 3 months, the patient is able to sit, squat, and stand on his own feet. Now going in a bit complex kind of fractures, this is a fracture which is fracture transverse with posterior wall of the acetabulum fracture. And in such kind of fractures, most of the times we have to go from both the approaches. So first we address this fracture from the anterior approach. And as you can see that this in the anterior approach, there is a structure which is known as corona mortis. And this corona mortis is an osmotic vessel connecting the obturator artery. Basically, the obturator artery is a part of internal iliac system, and this obturator artery to the external iliac. So this it's a communication between internal iliac system and the external iliac system. So if this artery is breached, is ruptured during the surgery, then it can give rise to torrential hemorrhage and the patient may die on table. That's why the name corona mortis. And so first we have to ligate this artery, we have to identify this structure, and then we went ahead with the identification of the fracture, and we applied a plate from the anterior aspect. After 7 days, we again went ahead with the posterior approach. We removed some intra-articular loose bodies that were present because these fragments can give rise to osteoarthritis in very near future, and then we fixed from the posterior aspect. There are sophisticated instruments that are required for reducing this fracture. As you can see in this case, these all instruments are there in our trauma center, and that's why we are able to manage such kind of patients. And this is the immediate post-operative radiograph, and in the CT scan you can see that the hip joint is well reduced. However, in the patient everything was going fine, but in the immediate post-op period the patient was slightly irritable, and he pulled urinary catheter all by himself, and there was urethral injury. He became septicemic because of the Klebsiella bacteremia, and he had to be transferred to ICU within 2 hours. And later on, this patient was managed by suprapubic cystoscopy by the urology department. And this patient again emphasizes the importance of multidisciplinary effort, because had this patient been operated elsewhere, we would not have been able to revive this patient. And at 3 years, you can see that the patient is back to his normal life. There is a bit of heterotoxic ossification that can be seen because of the extensive surgery that we had done, but then this is not clinically that bothersome because the patient is back to his normal life. Now this is the last case, again a similar kind of case. We did the anterior fixation firstly, and then we went ahead with the posterior column fixation. The reason I want to emphasize this case, want to highlight this case, is that usually the sciatic nerve is a single nerve bundle, but in certain cases we have two different divisions of the sciatic nerve, the common peroneal division and the tibial division, which eventually combine to form the sciatic nerve, and one of these divisions may be passing right through the piriformis muscle. So if we are not aware of the anatomical variations of the sciatic nerve, we may inadvertently lead to the damage to the sciatic nerve, which can give rise to foot drop in the post-operative period. So these are the variations of the sciatic nerve, and since this was one of the rare cases, we published this as a case report. And you can see that the patient, this is a 24-year-old female patient, and she is back to his normal life, her normal life. So based on the cases that we have done, we have not managed a huge number of cases, but based on the cases that we have done, our take-home message will be that the pelvic fractures will be managed as an emergency to control the ongoing blood loss, and in certain cases surgical management is required, especially in the unstable variety of fractures, and the acetabular fractures require open reduction internal fixation in most of the cases. So that is all about from the orthopedic side. Now I'd like to invite Dr. Kuldeep Vishwakarma, Assistant Professor in Oral and Maxillofacial Surgery, to come up with his presentation. Thank you so very much.
Okay, sir. Okay, sir. Thanks, sir. So thank you, Dr. Pesa. So from the specialty of oral and maxillofacial surgery, in today's CGR, I will be discussing complex mandibular fracture, which are associated with mid-face fractures. So the mandible form the lower third of the face, and the incidence of mandible fracture is 36 to 59%, and it is the 10th most common, most often injured bone in the body. The etiology being motor vehicle accident followed by fall, sports-related injuries, and interpersonal violence. So till date, we have operated around 60 cases of mandible fracture. Of these, 58% were isolated mandibular fracture, and 42% were associated with another mid-face fractures. So what are the complex mandible fracture? These are having multiple fracture lines resulting in 3 or more fragments in the same region of the mandible. So the treatment of when these fractures are associated with another mid-face fracture, this makes the treatment even more challenging. So the proper sequencing and of reduction and fixation is important in this case. In today's CGR, I will be discussing 2 of such cases which we have operated at our center. So this is a 28-year-old male patient who suffered a motor vehicle collision, and at the time of initial presentation, he was found to be hemodynamically unstable, and he was sustaining only exclusive maxillofacial injuries. Coming to the radiographic examination of this patient, as we can see, There is fracture in the symphysis region resulting in a vest-shaped fragment in the lower border of the mandible, fracture of the right subcondyle, and there was a fracture at the Lee-Fort-1 level. In the inferior view, we can appreciate the condyle, right side of the condyle is dislocated anteriorly. There is dicapitular fracture of the left subcondyle, left condylar head. There was fracture of the symphysis and displaying of the lingual cortical plate resulting in flaring of the mandible. In this image, we can see there is posterior and downward displacement of the mandibular maxillary complex resulting in posterior gagging of occlusion, loss of vertical height of the ramus, and anterior open bite. So as we can see here, the mandible is fractured and it is in 5 pieces. And but we can see here that maxilla is in the maxillary palate there is a single fracture. So we started with the palatal fixation first. So we exposed the palatal fracture through intraoral incision and reduced and fixed it with 1.5 mm mini plate to restore the width of the maxilla. And this restored width of the maxilla then will serve as a guide for subsequent reduction of other fractures. So we exposed the mandibular symphysis region through extraoral incision and reduced and fixed it with 2.5 mm reconstruction plate. We exposed the condylar fracture through preauricular incision. As we can see here, the proximal fragment is dislocated medially and anteriorly. We reduced it and fixed it with specialized condylar plate. So as we can compare our results, here we can see the post-operative CT of the patient. The condyles are well seated in their respective glenoid fossa. The palatal fractures are well reduced, and this is 2-year follow-up image of the patient. The width of the lower third of the face is restored, and good occlusion post-operatively. So here is another case of this is a 22-year-old male patient. He also suffered a road traffic accident, and on initial presentation he was hemodynamically stable. And as we can see here, the injuries involve all the thirds of the faces extending from the scalp, the forehead, upper lip to the chin. And actually this patient reported to us 4 to 5 days after trauma, and there were so many contaminated wounds. Coming to the radiographic examination of this patient, as we can see, there is a fracture of the frontal table of the anterior table of the frontal sinus, fracture of the right zygomatic bone, fracture at the Lee-4-2 level, and fracture of the bilateral body of the mandible. In the inferior view, as we can see that both the condyles are well seated in their glenoid fossa. However, there was a palatal fracture, but it was well reduced. So in this case, we go ahead with. So this case, since this case had so many injuries over the face, so we opted for a submental intubation in order to avoid tracheostomy. We exposed the bilateral body region of the mandible through submandibular incision, fixed, and other fractures were managed with 1.5 mm mini plates. So 3-month follow-up image of this patient. At this time, this patient reported with double vision. As we can see, this is a 3D deformated image of the patient. As we can see, the projection of right eye is diminished. In the 3D deformated image, we can see there was a defect in the orbital floor of 30 to 38 millimeter. So in this patient, we planned for a patient-specific solution. We printed this patient-specific implant since this patient had so many lacerations. So this time we went for a scarless surgery through transconjunctival incision. We exposed the orbital fracture, and we placed the patient-specific implant and fixed it with 1.5 mm screws. So this is the post-operative image of the patient, 1-year follow-up, and good occlusion between whatever the teeth he is having. So in conclusion, we can say that mandible fracture are common injuries, and most common cause is motor vehicle accident followed by falls, assault, and sports-related injuries. The unique anatomy of the mandible and other associated fractures make the treatment challenging. Various treatment strategies and sequences are exist, but should be customized for each and every patient in order to obtain good results. Thank you. Now I call Dr. Siddharth to continue with his presentation.
Thank you, Dr. Kuldeep. A very good morning, all of you. I'm from the specialty of physical medicine and rehabilitation. As Dr. Rajkumar sir and Dr. Amit told us that trauma is increasing every day in our country and it is creating a big hazard for the population. I would like to add in the same line that children are a vulnerable group of population who are suffering a lot from traumatic brain injury. And despite the good treatment, although they have a good chance of recovery in children, but they suffer from long-term consequences such as behavioral issues, cognitive impairments, emotional impairments, which prevent them from continuing their normal life and return back to school. I would like to present a case of traumatic brain injury in a child and how rehabilitation played an important role in his recovery. So we had this 8-year-old male boy with a history of alleged history of fall from 15 feet height. He came to us with left side extradural hematoma with multiple contusions, fracture of the shaft of the femur of the left side. He was in shock and poor sensorium. At the time of admission, his GCSS score was 8 and he was a severe category of head injury. Patient was stabilized in ICU, followed by burr-hole craniotomy, followed by evacuation of the hematoma. Rehabilitation was started while the child was under ICU care to assist the acute care team in preventing complications such as contractures, pressure ulcers, heterotopic ossification, and the bladder and bowel problems, which may impede later rehabilitation of the surviving patients. The length of stay in ICU was 23 days, and he was weaned from ventilator and decannulated. Once the patient was medically and surgically stable, he came to us and he was transferred to the rehabilitation unit. Once he was with us, we did a thorough examination, evaluation, and assessment. The neurological status, what was the ADL status, what was his functioning levels, the FIM score and Barthel score were noted. On observation, we found that the child was having right hemiplegia. He was having spasticity on the right side, and he could not walk at that time. He had impaired balance and perception. There was poor cognition. Memory was poor. He was in agitated state. He was having behavior and skill defects. And because of the hemiparesis, he was having limited range of motion on the right side with altered gait. The rehabilitation program was planned accordingly, the tailor-made to the requirements of the child. And after the consent of the parents, it was started as 4 times per week of neuromotor rehabilitation, twice for speech therapy, 4 per week for metacognitive therapy, and twice a week for neuropsychomotor therapy, for which we also seek help of our psychiatry SR who helped us with that. He was started on subacute rehabilitation. Our short-term goal was to expedite the recovery of the physical and cognitive impairment and to limit the disability the child was expected to have. And long-term goals was to have a maximum functional independence, good psychomotor functioning, and we wanted him to return back to school, community, and his leisure activities. Early rehabilitation strategies included spasticity control through the medicines and physical therapy. Early mobilization, we started bedside mobility of the child. We taught him transferring to the chair to toilet seat and ambulation. Training of the ADL functions, muscle strengthening and proprioceptive training. And he was given an AFO brace and started on neuromuscular electrical stimulation. For the cognitive part, we taught him the behavior management, daily life skill trainings, community activities, pre-vocational activities, and behavior training methods. For example, we taught him to break down the entire process into small steps. There were memory drills. He was given a task with some cues so that he's able to do a task in a repetitive way that can enable him to regain his lost functions, and positive behavior reinforcement as well. He was also having dysphagia, for which we started with changing the texture of the food and placements and head position. There are different maneuvers for the dysphagia management, for which he was started on. There were oromotor muscle strengthening exercises. And most importantly, his family and caregivers were involved in all throughout this process so that they know what is the feasible expectation and how they are supposed to continue the care at home. The neuromotor and cognitive clinical situation improved tremendously during the 3 months of extensive therapy, characterized by an intensive multidisciplinary rehabilitation program. Barthel score improved from 10 at the time of admission to 65 at the date of discharge, and FIM score improved from 72 to 104. We also did a gait analysis. I unfortunately don't have a video. I've managed to lose the video, so I cannot show the video. But during the initial phase, when he was brought to us, he could walk with a wrist and elbow in the flex position, and gait was characterized by anterior elevation of the left pelvis during the pre-oscillation phase and external rotation of the left hip and knee. At 12 months, he wore viscoelastic orthotic plantar and orthopedic shoes, and he was able to make rapid movements, start and stop, and the change of direction, even if with difficulties. Currently, the child comes to us on the OPD basis, and I'm happy to see that he is going back to school. He's able to write. And a very amusing part is he was right-handed before trauma, but because of his injury, he has managed to learn writing from the left side. And currently, he has become ambidextrous. He can write from both the hands. So I would like to conclude that although numerous researchers have already highlighted what devastating effects have a brain injury on cognitive, motor, and sensory functions, from my experience, I strongly recommend and suggest a comprehensive multidisciplinary rehabilitation protocol to promote recovery and facilitate a smooth transition to home and school activities. The importance of early and regular communication between rehabilitation team, family members, and educators is also strongly recommended. This is the picture of the child when he was about to discharge. He gained his balance. He was able to walk at that time. Thank you. I would like to invite Dr. Rupali to bring her presentation.
Thank you, Dr. Siddharth. Good morning, respected teachers and my dear colleagues. I, Dr. Rupali, will be presenting from the laboratory medicine. Laboratory medicine has been providing round-the-clock services for the patients, and it is giving services in the various subdivisions related to hematology, coagulation. So it is laboratory under one roof. And so far, we have been doing a panel of tests, and on the screen, you can see the various test parameters that we process. So far, since the inception of Trauma Center, we have processed up to 6 lakhs tests, and for the subdivision of the test, clinical chemistry has the maximum test parameters, followed by hematology, coagulation, and the rest as shown in the graphs. Now, during the time of COVID, that is in the year 2020 and 21, few parameters were added as per requirement for COVID patient care services. So like ferritin procalcitonin in immunology. During this tenure, we have had various publications in trauma as well as COVID. I would just like to discuss about one of the studies that we published during the time of COVID. Now, as we all know, for COVID prognosis, we used various investigations in blood as well as radiological investigations. So like ferritin, procalcitonin, quantitative D-dimer, these tests are requiring high-end analyzers, they are costly and CT scan. So why not come with something which is cheap? Because especially during this time when the study was planned, that is during the Delta wave, second wave, there was a huge load on the healthcare services. So taking the complete blood count and the morphological changes in the various cells, that is red blood cells, white blood cells, and platelets, this test was done. A total of 92 patients were recruited, and on admission, their peripheral blood smear was assessed for the various changes. Now, we did not find significant changes in the red blood cells. However, we did find certain significant changes in the white blood cells. This is a pseudo-Pelger change in the WBC. Then there was increase in the number of apoptotic leukocytes. Then the changes in the lymphocytes included reactive changes. Now, some of the leukocytes, they had a marked reactive change, giving them a plasmacytoid appearance. Also, this is the in figure D, the lymphocyte is reactive change. Now, here the monocyte cell was also involved. It showed abnormal vacuolation and nuclear lobulation, while the platelet changes in the platelets were presence of giant platelets, satellitism, and increase in granularity. Now, using univariate and multivariate analyzers, we found three parameters to be clinically significant, and using these three parameters along with presence of comorbidity, as about 67% of the patients admitted had comorbidities, a scoring system was devised and a total score of 9. Now, all the patients that were recruited were scored, and it was found that patients who had a score of more than or equal to 4 went on to have severe course of disease, and approximately 45% of these had a mortal outcome. The diagnostic accuracy was seen for this scoring system, and it was found to have a specificity of 75% and sensitivity of 73%. So to conclude, the peripheral blood smear morphological examination, it requires minimal expertise and minimal resources, and it can be used not only for the scoring, but even in especially in a sources where there are limited resources, it can be used to monitor and assess the daily prognosis. That is all from my side. Now I request Dr. Ashutosh to continue on with presentation from neurosurgery.
Yes, sir. Sure. I'll keep my presentation short. Yeah, I'll finish in 4 minutes. Sir. Okay, so I'll just show the census and few interesting cases. Good morning, respected seniors and colleagues. I'm Dr. Ashutosh. I'll be presenting a short experience of neurotrauma at Apex Trauma Center. During the last 1 year, we had an admission of 221 patients. Of these, 79% patients required surgical intervention. 21% patients were managed conservatively. The spectrum included patients who had cranial, spinal, and peripheral nerve injuries. Among the patients who were operated for cranial injuries, subdural hematoma was the most common cause. It was followed by cerebral contusions and extradural hematoma. The other injuries included depressed colbone fractures, post-traumatic non-communicating hydrocephalus, and gunshot injury. Among spinal cases which were operated, cervical injury was the most common. It was followed by thoracic and lumbar spine. COVID-19 has been a major impediment to the functioning of Apex Trauma Center and neurotrauma. As compared to the census of previous 2 years, there was drastic decrease in the number of patients who were admitted at Apex Trauma Center under neurosurgery. But when we see the total number of admissions and cases operated per month over the last few months, there has been progressive increase in the number of cases. These are few representative cases which exemplify the role of. So should I short it further? Okay, so this is the I'll discuss just one case which exemplifies the role of teamwork in the management of neurotrauma cases. This was a 28-year male who had presented with alleged history of assault with sickle. Multiple wounds were inflicted over his scalp and face, and he was resuscitated and shifted to CT, where he was diagnosed to have multiple calvareal bone fracture and facial injuries. A part of bone had also migrated into brain parenchyma and was lodged near the temporal horn of the lateral ventricle and the Sylvan fissure. Patient was operated, craniotomy was done, the fractured bone fragments were removed, including the bone fragment that had gone into the brain. Perisylvan contusions were resected and a repair of facial injuries were done. Patient in post-op period had recovered very well, and this was a case which was managed along with the OMFS team, the anesthesia team, and the neurology team. So overall, we see that neurotrauma makes the major chunk of patients who are being admitted at Apex Trauma Center. However, with team effort, we have been able to provide the best of care and outcome to such patients. Thank you. Now I invite sir. Okay. Sir, we'll continue with the discussion. Sorry, sir. Publications, yes. These are few publications that has been published from Apex Trauma Center. Thank you, sir.